recording. Sorry, what did you say? You lapsed for a second.
Sorry, I was gonna start admitting participants.
Perfect. All right. Hi, everybody. Thank you so much for joining us today. We're going to wait a couple minutes or so to let everyone trickle in. But in the meantime, thanks again for joining us. This is the 8th event in the Recovery Science Series webinar hosted by the Recovery Research Institute at the Massachusetts General Hospital. This is an Opioid Response Network sponsored event, sponsored through the American Academy of Addiction Psychiatry. Today, our webinar title is Collegiate Recovery from Science to Policy, presented by Dr. Noel Vest. My name is Maya Matlack, and I am a clinical research coordinator at the Recovery Research Institute. I am joined by Chris Raton, the health communications coordinator at the RI. We are the co-hosts today, so feel free to send us a chat if you have any questions. Just to give everybody joining us a brief rundown on what to expect today. If you've come to our previous events, this will be a familiar format. We're going to get started with a brief introduction, which will be followed by a few polling questions. And then I will introduce our presenter, Dr. Noel Vest. We will have a question and answer section during the last 10 to 15 minutes of the webinar. So feel free to put questions and or comments in the chat throughout the presentation, and we will answer them at the end. Okay, and for those of us just joining us, welcome again officially. This is our 8th webinar in the Recovery Science Series, sponsored by the Opioid Response Network. I'm going to get started by playing a quick video to give everyone an overview of the Opioid Response Network. If you've attended our events before, I'm sure you're pretty familiar with this video, but here is just a refresher for everybody.
Communities across the nation are mobilizing to address opioid and stimulant use in the overdose crisis. We can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org. Communities across the...
Okay. And just briefly, these are our past events. The recordings and the slides can all be accessed on our website, which I will put the link to our website in the chat shortly. And keep an eye out for our next webinar, which will be held exactly 3 weeks from today on December 7th. We are very excited to have Dr. Keith Humphreys presenting on mutual help groups. Registration is currently open for this event, and I will also put the Zoom registration in the chat shortly. And here is today's event. And before I introduce our speaker, I just want to run a quick poll for our attendees today. I will go ahead and launch it. There are 5 questions total in this poll, so make sure you scroll down to read them all. We have 3 questions just kind of about your background, and then 2 from our speaker today. And we'll leave this up for about a minute or so to give everyone time to complete. Okay, awesome. We're at about 80% response. So I'm going to go ahead and end the poll and share the results. And Dr. Vest will actually reveal the correct answers in his talk. So with that, I'm going to stop sharing my screen. Okay, so thank you everyone who answered the poll questions. Now, without further ado, it is my pleasure to introduce Dr. Noel Vest. Dr. Vest, PhD, is an assistant professor at the Boston University School of Public Health. As a formerly incarcerated scholar, Dr. Vest is an advocate for social justice issues and public policy concerning substance use disorder recovery and prison reentry. His research interests include mental health, substance use disorders, poverty, social justice, addiction recovery, and pain. He was recently awarded a KO1 Early Investigator Award from NIDA to study collegiate recovery programs through an implementation science lens. He received his PhD and master's degree in experimental psychology from Washington State University. He recently finished a postdoc in the Department of Pain Medicine at Stanford University. So without further ado, take it away, Dr. Vest.
All right, make sure the first thing you always have to do on these things is make sure that you're off of mute, right? All right, so I will go ahead and get started. First of all, I would like to thank Maya, Dr. Kelly, Bettina, everyone at the Recovery Research Institute for allowing me to present today. It really is just a great honor to be able to present in front of all of you. And so without further ado, I'll go ahead and get started. As Maya mentioned, I was recently awarded a KO1, and that's the project that I'll actually be talking quite a bit about today. Other than that, I have no conflicts of interest. And I would also say that by no means is this project completely flushed out just yet. Just starting on the training goals this year, and with the meat of the project yet to come. But again, hopefully I can share with you what that's going to look like. So I always like to start off my presentations just giving a little bit of background. One thing that I've always appreciated when I hear someone speak, just as much as I hear them, or just as much as I love listening to them talk about their research, I also like to understand what formed their research questions, what life experiences that they had that kind of led up to the questions that they are asking. And almost inevitably, I think sometimes that story is even is sometimes more interesting than the research itself. And so I'll go ahead and give a little bit of snapshot on what led me to this led me to my career in higher education. So I always start off with this story about being a very motivated third grade student. I was that kid that learned their times table in one day, was 100% on all my assignments. My teacher noticed that, and so I tested into the gifted program. But I didn't get in. I didn't get into the gifted program, and that set in motion really this, concept in my little brain that I wasn't one of the smart kids. And so likewise, I really didn't take school seriously for the next 25 years of my life. In the meantime, addiction ravaged my life and resulted in a 7-year prison sentence in the Nevada Department of Corrections, where luckily I found recovery. But at the same time, I feel very, very fortunate that the College of Southern Nevada got a grant to come in to the Nevada High Desert State Prison and offer college classes. And so I think that without that, I would have never even thought about a career in higher education. But that college and prison program provided just enough evidence that with some motivation and some newfound study skills, that college may be possible when I get out. And so that gave me just enough courage to show up at my local community college and start my training really to become a drug and alcohol counselor. And I went to Columbia Basin College for 2 years. I did become a substance use disorder counselor at a place called Somerset Counseling, and graduated from community college. I learned very quickly that I was not a very good drug and alcohol counselor. I think that it takes a certain aptitude or skills in motivational interviewing that I just didn't naturally have. But luckily, I was already in school, and so I would say that really kind of took me to part 2 of my educational journey, which started at Washington State University. This time it was at the Tri-Cities campus, the local campus to where I had paroled out to. And there I earned my bachelor's degree, but I think even more importantly for me was that was where I had kind of ventured into or stumbled into the wonderful world of empirical evidence and science. And so that really kind of gave me this new found, I think, freedom or newfound skill set that again I think was hidden for quite some time. And so I graduated from Washington State University Tri-Cities with a bachelor's degree. But I think more importantly, one of my mentors at WSU somehow convinced me that I should apply to graduate school. And so I did. This time I got into Washington State University. This was the Pullman campus, or what they kind of call the mothership campus in Pullman, Washington. While I was there, earning my PhD, I also helped found a collegiate recovery program called Cougs for Recovery. And very, very fortunate, as I was winding down my graduate school, very, very fortunate to attain a postdoc here at Stanford Medicine, and working with I think coincidentally, working with Dr. Keith Humphreys, who will be presenting here in just a couple of weeks. And so while I was here at Stanford, I also started helped found a collegiate recovery program here. And I think that both of those experiences, because I think in both of those experiences, what I struggled with most in helping start these programs was that there was little to no research or to guide starting or sustaining a program. And so that kind of stuck with me. And so that's why I decided to write up a KO1 examining collegiate recovery programs. As was mentioned, I was just hired recently at the Boston University School of Public Health. I started there on the 1st of September, though I am finishing my fellowship here until next summer. So I live here on campus at Stanford until next summer, but working remotely at the Boston University School of Public Health, which is where I'm going to be completing this research project. So one thing that so that kind of what shapes why I'm kind of interested in this, but then also kind of gives you a snapshot of why recovery and why substance use disorder is so important in the research that I do. So I think one of the great things, one of the perfect mentorship opportunities I learned early in grad school was that an early mentor told me you never want to have just one research track for your research. You want to at least have 2 or 3 areas that you're interested in, because you never know when when funding is going to dry up in one area, or it just kind of becomes out of favor. And so I took that to heart. So I really have kind of 3 research areas that I focus on. I would say first and foremost, and this was evident in early grad school, was that I always wanted to focus on this idea or the intersection of mental health and substance use disorders, just kind of generally. Later on in grad school, I started I started looking at statistical analyses and fell in love with, I would say, cluster modeling of substance use disorder. And so I also have a research track where I do a lot of collaborations looking at clinical trials network data and other data sets to try and figure out specific patient groups that we can provide interventions for through cluster modeling and latent class analysis. And then most recently, I've become interested in the implementation of collegiate recovery programs. So how can we understand it through the lens of implementation science? And so that is the one that I'm going to focus on here today, the focus on collegiate recovery programs. So first, I just want to take a couple of moments and really just kind of lay the foundation regarding collegiate recovery programs. I think that it's kind of, in order for us to really kind of be on the same grounding, I think it just is good to talk about addiction generally before I get into the specifics on collegiate recovery programming. So the next few slides, I'm just going to kind of lay the foundation, and I'm sure a lot of this stuff is going to be a refresher for everyone on this call. So the first thing I don't think that I need to say, but I will say, is that our country is facing an addiction crisis. I think that we've been facing an addiction crisis for way before this chart actually shows. But the truth is that we're all kind of searching for solutions. As you can see from this chart, we have had the largest overdose death rate in our history. And this is not a new phenomenon, right? We've seen similar public health related outcomes with alcohol prohibition, as distilled alcohol kind of took over for or replaced beer and wine. And so these kinds of trends are not anything that's new. And so I think that when we think about collegiate recovery programs, when we think about the overarching addiction crisis that our nation faces, this is just one small solution to that addiction crisis, but I think it's an important one. If we look at the evidence, there are reportedly, or it's estimated that 600,000 college students are in recovery from substance use disorder. So finding ways to make sure that we're providing services to those individuals is obviously an important one. Next, I just want to talk about this slide for about 2 seconds. This actually comes from Carl Fisher's new book. He's a psychologist at Columbia who wrote a book called The Urge, and I really loved in one of the first few chapters, he kind of talked about this. And I think that it really is important to kind of point out that, I have friends, I have tons of friends that are in recovery. I have tons of friends that are not in recovery. I have tons of friends that are kind of in the addiction world. And I have friends that say, syringe exchange saved my life. I have friends that say methadone absolutely saved my life. I have other friends that say 12-step saved my life. I have other friends that say therapy absolutely saved my life. And then I have other friends that say, prison absolutely saved my life. And I think it's important to understand, right? We live in such a polarized society today, and the addiction landscape that, you would think that none of these statements could ever be true simultaneously. But the truth is that they're all true, right? So personal experiences shapes our opinions. And I think more importantly, it shapes our biases about what addiction recovery is. And so I think we can all agree that the goal should be to minimize harm and to help people live with and beyond their suffering. And so, in other words, I kind of just include this in this encompassing definition of kind of what recovery is. But it's important to understand that other people may have differing opinions based on their kind of approach to addiction. Another thing that it's really important to touch base on is the continuum of care, right? So when we're talking about really any disease, it's not just substance use disorder, any disease, they all follow a continuum of care. And I think importantly, you have different pots of money for the different areas of so different research and services associated with each level of care, right? So in the way that our country works, you have a pot of money that is important for prevention. You have a pot of money that is kind of important for the treatment of, and I'll just say substance use disorder, but it could apply to any disease. And then a pot of money that is important for the recovery end of the spectrum of care. So what I will just say generally is that similar to recovery community centers, the same kind of applies to collegiate recovery programs. We are generally, and again, I say this very generally, talking about services at that far end or that far right end of the continuum of care, those kind of recovery, what we would kind of consider recovery-based services. Though some services, I can speak for the collegiate recovery program here at Stanford, some services, for example, Narcan distribution, I think you could say, which is a very important part of our collegiate recovery program here, span all three phases of this continuum of care. But again, generally speaking, when we talk about collegiate recovery programs, the majority of the services that we're talking about are down at that far right end of this continuum of care. And so a little background on collegiate recovery programs. So college substance use, I don't think I have to tell anyone here, it's a major public health problem, and it represents probably one of the most prevalent reasons for student dropout. But honestly, little support exists for students wishing to sustain or enter into substance use disorder recovery. And so if we prioritize recovery services, I think it can obviously reduce the burden that these students face and destigmatize individuals with substance use disorder across campus and across our society, I would say as well. And to give kind of a very broad definition of what I'm considering collegiate recovery programs, and at least in the context of this talk, is that it really can be any kind of organized programming to support students in addiction recovery, and that's both behavioral and chemical addictions. And so again, a very broad definition of what that may be. So next slide, what we'll talk a little bit about is the history of collegiate recovery programs. And this has kind of gone in what I consider three phases. So you had the initial collegiate recovery program, 1977 at Brown University. That program, from what I understand in talking to people, was what they would kind of consider fledgling. It would kind of go into favor, it would go out of favor. It would have a lot of students, it would not have a lot of students. And so it would again kind of wane in and out for the first few years of that program. But what it ushered in was kind of this first wave of collegiate recovery programs. And so from 1983 to 1997, you saw three very well-supported, well-funded, and strong collegiate recovery programs at Texas Tech, at Augsburg, and at Rutgers University. That kind of held true until the early 2000s. And then what you saw was what I would consider the second phase of collegiate recovery programming. Both SAMHSA and the Department of Education went to Katie Harris at Texas Tech and said, hey, we would really like it if you could create kind of a playbook or a toolkit for other schools to kind of replicate what you've done here. And so she went to work, created what's still the only real strong toolkit to get collegiate recovery programs started, but that ushered in kind of a new phase of collegiate recovery programs. So from about 2005 to about 2013, you saw collegiate recovery programs grow from about 33 in number to about 30 in number. And then in 2014 started the third phase of the expansion of collegiate recovery programs. So the Stacey Mathewson Foundation, which would become the Transforming Youth Recovery, created a seed grant program which allowed colleges to apply for these $10,000 seed grants, very low barrier as far as whether they would get the money. So a lot of schools got this $10,000 to start a collegiate recovery program. So you saw really a huge increase from about 30 programs in 2013 to about 140 programs that you see today, give or take about 140 programs. And so that's kind of the history and the ushering in of the different phases of collegiate recovery programming. Again, this is by far not an exhaustive list of the kinds of services that you'll see at a collegiate recovery program. I would say that not all collegiate recovery programs have all of these. In fact, I would say very few have all of these. And it's really just kind of a mix of different kinds of supportive services for collegiate recovery programming. So this next slide I stole this from Dr. Kelly a couple of years ago, but I do think it really helps us to understand how we can shorten that. When we think about the ways that we can shorten that time span, right? So this is kind of a seminal work in the recovery space, kind of showing how long it generally takes for a person to enter into long-term recovery, right? So we see kind of this early phase. We see 4 or 5 treatment attempts, and then a person some maybe 17 or so years later.
Neil, you're muted.
Recovery. And so that's I think collegiate recovery programs can obviously play, just like recovery community centers can play a big role in this. And so I think that another thing that's kind of important to understand when we talk about kind of this recovery time span, right? So I think a lot of times people think that you start a collegiate recovery program and then you just have all of these students that are in remission and enhanced quality of life, and which may or may not include abstinence, but you have these improvements in students across time, and this is the role that I think this is the timeline that people think that it takes, but it's actually a little bit different. So I've always enjoyed Dr. Kelly talk about the burning building analogy. For anyone that hasn't seen that, he basically states that we're really good at responding to the addiction in a person, right? So we're really good at responding to the fire and putting that fire out, which means that we have really great services around acute care, but we don't put as much energy into funding research on what happens afterwards, right? So the recovery phase or the post-treatment phase of a person's life in this continuum of care. So while we may think of it this way, it's actually much more complex with the person and then also contextual factors. So it may look something like this when we think about success or the lack of success. And for some reason I can't. There we go. And so it may look something similar to this, right? So collegiate recovery programs, we have this increase in recovery capital, or kind of the context for recovery for a person. That helps to lead to these biopsychosocial changes that are important for long-term recovery, and then we see kind of this remission. And again, this is a very simplified timeline, but I think that it really kind of speaks to kind of what's happening when we talk about the changes that are happening in collegiate recovery, or for people in collegiate recovery programs. Okay, so finally, I'm going to jump into some of the science here. So this is, I think, a really, and I'll come back to this. This is out of a recent paper that I published, and it's understanding, right, and we've talked a little bit about the individual, right? So we know that collegiate recovery programs are important to the individual, and the other thing that's important to understand is that people in recovery only recover within contexts or settings, right? Or surroundings. And the best results are often realized in the most supportive environments, right? So we have all these individual outcomes, or these individual things that are important to a person's recovery, but that is nested, or that is happening within this interpersonal relationships that a person is having. It's also nested in the kind of the school environment that person is living in, but then it's also nested in, which is also nested in a policy environment or a community context. And if we're not understanding that each of these are important for that student in recovery, I think that we're really kind of missing the boat. And so this is really kind of driving the research that I'm proposing and hopefully completing over the next few years. I'm going to go over this paper real quick. This is, I've talked about this many times before. I will definitely at the end put this publication in the chat, or have Maya send it out at the end. This is a publicly accessible scoping review that was published a couple of years ago. This is the PRISMA statement. And again, so when we look, and this is really going to point to kind of where the research has really kind of failed us when we're talking about collegiate recovery programs, right? So I just want you to imagine this, right? So there were when we did the scoping review and we looked at all of the articles that mentioned collegiate recovery programming, and if you could imagine that any other recognized disease, diabetes or cancer or anything like that, there would be thousands of journal articles on college age or emerging adult individuals with that disorder or with that disease. So this is really part of a larger problem, that recovery in substance use disorder is largely ignored, I would say, by at least in the research world. And so I think that it's getting better, but for a long time, it really has not been prioritized as it has in other diseases, and especially by the funding sources. And so this really kind of makes sense when we look at the number of publications that looked at college students. Quite a few of them actually looked at college students. Some of the other papers looked at alumni, and some looked at college administration. The number of participants in each are, again, not exactly what we would want to see. We would love to see these very robust samples with over 500 students or 500 people. And then in the next slide, we kind of, we didn't attempt to evaluate the rigor of this or the quality of this, but I think it's clear from some of these basic identifiers that were reported in these studies that the quality is not ideal. And so you can see that many of these papers did not even evaluate a person's gender. They didn't ask about behavioral addictions, which are very, very important because they often co-occur with substance use disorder. In a lot of these studies, they didn't report race. And so that is very telling. Either they didn't feel it was important enough to look at race, or there was not enough disparities, or there was not enough diversity that they could even report it. Either of those problems are just unacceptable in the research world. And so, and then the last one that I'll bring in is that, you know, just even asking people about mutual help groups. This, I think, is one area that, you know, is pretty clear. The research is clear on mutual help groups. Obviously, not one program works for everybody, but I think there's enough research to show that mutual help programs can be very effective for people in recovery. And so that they didn't even ask about that in almost 60% of the studies is again, I think, very telling. This really just kind of shows that these are many of these studies are either cross-sectional or qualitative interview style studies. So not that scientific rigor that we would see with a randomized controlled trial or clinical controlled trial or a secondary controlled trial. These are the primary outcomes, the lived experience kind of being the king, these qualitative interviews asking about lived experience. And I think this, when we're talking about rigor, is the most telling. And this, it kind of paints a picture that is much more rosier than it actually is. So this shows two NIDA-funded studies, but actually these are the same papers. And so there has only been one NIDA-funded study, the NIAAA study, and I apologize for the font being very small on this, but that's just what my PowerPoint did. The NIAAA study was actually not even on collegiate recovery programs. It was a biofeedback study that just happened to have people in collegiate recovery program doing the test. And so this is not just college students in recovery. Recovery in general, I would say, has been ignored by the funding agencies. But again, paints a larger picture of that just kind of the problem here. And then obviously I would note that my before this paper was published, my KO1 was not funded yet, and so mine would make two NIDA studies to look at collegiate recovery programs. I think with what we can say with these with this scoping review is that, you know, collegiate recovery programs are kind of associated with these positive things that we know are helpful for people in recovery. I think that what we found is that they're kind of suggestive of these other things. You know, not a whole lot of evidence. I think without question we can say that we need more research and more high quality research. And so I think that, you know, when we look at what remains unanswered, I think that we really need a framework to kind of guide implementation of collegiate recovery programs. We need to understand what they look like today. And then we also need a toolkit to kind of guide collegiate recovery programming implementation. These are two studies that I'll kind of summarize as I talk kind of moving forward. And again, I will definitely make available to everyone by the end of either by the end of this or have Maya send it out to everyone. This is the research team for my recently awarded grant. I'm going to, on the next slide, try and make implementation science as easy to understand as possible. I think that it is, you know, when we think about science in general, right, it's important to understand that just because we have some kind of best practice or evidence-based intervention doesn't mean that those are always implemented the way that they should be. And so implementation science is much more focused on how the intervention is implemented, rather than trying to, you know, prove whether the thing works. So the thing is the intervention, and when we think about implementation science, implementation research, we're looking for how to best help people do the thing. And so I'll talk about the things here in just a minute. This is a great paper. It's a great paper because it's a one-page paper, and I think that this it's Dr. Karan made this paper, and I'll definitely make this available as well. But for someone wanting to understand implementation science, it really lays it out fairly simply. So when we're thinking about best practices as they relate to collegiate recovery programs, what we identified was that there was kind of three best practices, right? So the first being some kind of self-help group, right? So all recovery, AA, Al-Anon, medication-assisted recovery, Celebrate Recovery, these kinds of mutual help groups is one thing that has been found to be a best practice. A second best practice is for a student drop-in center, some kind of place where the students in recovery it's a place of their own. They can drop in there throughout the day. They can study. They can print off things, but they have a place that is kind of their own. And then the third is peer recovery supports, and that's really kind of open-ended as to what that may be. But just generally, are there peers to help other peers in recovery? And so these are the best practices that we identified. What we're going to do is we're going to travel to each of these locations and perform an ethnography, kind of understanding these best practices and how they work within these contexts. And so these sites were selected because of their size. They're either public or private, the length of the time in the program, and all three of them have these best practices. So we wanted to make sure that we were going to a school that had these best practices. So kind of a diverse group of schools across the country. I won't bore anyone with this slide. This is what's known as the CFR model, or the Consolidated Framework for Implementation Science. This is just the framework or the model that is kind of guiding our programming. You can see on this slide, the idea at each of these schools will be to interview each of these 15 stakeholders in this. We have a couple of, we actually have a couple of negative cases from collegiate recovery programs, one at Riverside, UC Riverside, that failed. And so we'll also be asking questions there. You can see that these CFR domains really kind of map on to this, the reason that we're identifying these 15 key stakeholders is because we want to make sure that we have representation from each of these levels of what we know, this socio-ecological model, what we know is going to be important. We don't want just the student perspective. We don't want just the college administrator perspective. We want the entire perspective, so that can kind of guide our research, and so that we can really kind of find a way to implement these programs that's going to be beneficial for all of these stakeholders. And then lastly, this just kind of sums up the outcomes that we're hoping to look at. We're going to spend 3 to 5 days in each location identifying these barriers and facilitators, and hope to get started early next year. Aim 2 of this study is to replicate the only other study that's been done on collegiate recovery programs. Was done back in 2013. It's known as the Law Day study, and it was a national survey of collegiate recovery programs. So we're hoping to replicate that, hoping to get at least 500 students that will give us some very, very needed updated information. We hope to capture kind of the variability in these collegiate recovery programs. And then we also hope to capture the change that's happened from back in 2013. And then lastly, the idea will be to take everything that we have found and update that college recovery community replication curriculum that Kitty Harris, and so what we're hoping this will be is a toolkit, because I think that, one thing we know that is that collegiate, unlike a recovery community center, which, takes a lot of money to really kind of get off the ground, because you have to have a building, you have to have all of these things. I think collegiate recovery programs are something that really could be easily scaled up, because, you know, there are many colleges kind of across the country. And so the hope here is to add to the literature and guide colleges and universities with some very strong evidence, both now and hopefully in the future. And so I'm very, very hopeful that Dr. Kelly and Hepner will invite me back to the RRI in a couple of years to share these results and the new toolkit. And so that really kind of sums up the research or the science kind of part of this, and gives you a really good understanding of kind of where the research in this area is going, at least over the next couple of years, at least on my end. I want to spend a couple of minutes now kind of talking about policy. So let's take 5 minutes and then we'll get to some questions and answer. And just a reminder to put those in the chat, and Maya will get to those at the end. And so again, important to understand that these collegiate recovery programs exist within colleges that are either directly or indirectly promote alcohol and drug use. And so they tend to be resistant to change. This, despite a national, despite a nationwide addiction crisis that has impacted colleges, and I think more importantly, the communities that surround them. And so in order to properly advocate for collegiate recovery programs, we must drive home the message that collegiate recovery programs are not that student level intervention, right? They are a school and community level intervention focused on helping resolve our nation's addiction crisis and to reduce substance use disorder stigma on campus and across our society. And so kind of turning back to this model, understanding that the stakeholders at each of these levels are answering to people with different motives and different interests. But again, if we continue to focus on that individual level, it really creates, it is, I think it's very frustrating to me, and I'll expand on that here, because here's what happens. I travel across the country, I talk to people, I talk to students, I talk to administrators, I talk to collegiate recovery programming faculty, and I'm so sick of hearing, the same kind of tired message. When we advocate at the individual level and administrators ask, how many students will this program serve? That is not the question that we should be asking, right? So when I'm asked that question, I turn it back on the administration. I say, I don't know. How many are you actively recruiting, or how are you advertising to students in recovery in your recruitment efforts? The question is not whether addiction exists and whether addiction exists among college students. There is no doubt that it exists, just like recovery exists. And so I think that recovery community centers identified this really kind of some time ago, and that's why these recovery community centers are considered a community level intervention. And so we will always be behind the 8 ball versus alcohol advertising. That is a $7 billion machine, advertising behemoth that really preys on college students. And so while, I don't think that we'll never win the public opinion and dominant culture perspective, but, just as there is 70% of students that drink on campus, it's part of their college experience, that means that there are another 30% of students that are just as important and need to feel valued on campus, the students that are substance free. And so
Oop, sorry, Dr. Vest, I think
the
you
most
are
important.
muted.
I think understanding that will always be behind the 8 ball with alcohol advertising. It's very frustrating when I talk to administrators or I talk to students to hear that they are always struggling for funding. I don't understand why collegiate recovery programs basically have to hold bake sales every year, go out and beg for money that is their kind of funding solution. And I think that is a tired model, and we shouldn't be in that that model. Another thing that we need to understand is that these collegiate recovery programs are a system level intervention, not a student level intervention. While students benefit, this is a system level intervention. Important to understand that this is an underserved population that is highly stigmatized in our society. So some policy solutions, and then we'll move on to questions. We need to move away from the philanthropy funding model to a line item in state budgets. The state of Washington recently funded their collegiate recovery programs right out of their state budget. It was a line item, a budget proviso. It's possible. Another funding model that I've seen recently is the Blue Cross Anthem model. You saw that slide at the very beginning. That's happening in Pennsylvania. I think that is a great way to think about funding alternatives. Another, and I think probably the best way to do this would be through block grants from the federal government, but I think we're a long ways away from that, at least at this moment. Number two, these schools, these universities that collegiate recovery programs are fledgling in, rake in millions and millions of dollars to study addiction. They should be incentivized to support the students that they have that suffer from the disease. So it just drives me crazy when I see a school's budget of, 40, 100, $200 million in, funding from NIDA or funding from these agencies, yet they can't take any of that money and invest it in their own students that suffer from that condition. And then lastly, we need to move away from the individual student impact and focus on the impact that CRPs are having on our country. We're training tomorrow's workforce and leaders. Do we want them to have real world understanding of addiction? Do we want them to be sitting next to in class students that have suffered from this condition? I think it makes our society better. So just understanding that it doesn't take anyone can walk out the door of any university in this country. One of the biggest things that is facing that community is the addiction crisis, the overdose crisis. We need solutions. So that's where I would definitely say we need to kind of go. I put my email address, my Twitter handle on here. Feel free to reach out at any time. And it looks like we have exactly 10 minutes, Maya, for questions.
Great. Yeah. So thank you so much, Dr. Vest. That was a fantastic presentation. You have some really exciting research coming up. So thank you so much for sharing. So we have about 10 minutes to do a bit of a question and answer section. We have some questions in the chat already that I will read out, but of course, as things come up, feel free to drop them in the chat as well, or unmute yourself and ask. So the first question I see is, 3 essential elements of a collegiate recovery program are self-help groups, drop-in centers, and what else? I missed the last one.
Peer recovery supports. And it really is in line. If you look at the Association for Recovery in Higher Education, they have best practices kind of a section on their website. Though not pulled directly from there, it was definitely influenced by some of those best practices, and then based on kind of the literature out there in other, not just in collegiate recovery programs, but in other contexts that we felt that those were some pretty good best practices.
Great. And the next question is from Savannah. And they asked, is there any evidence for strategies to increase student engagement in the CRPs? Often I see students who would benefit from these programs, but they still don't engage.
Yeah, no, if you figure that out, please write me and let me know. I think that, that is one problem that happens across collegiate recovery programs. First of all, you're never going to reach everyone. I mean, that's just kind of the bottom line. People have different kind of opinions, different experiences that they are either kind of drawn to a collegiate recovery program or not drawn. And maybe they just won't be drawn to that particular collegiate recovery program. I think offering a wide array of services, so not just not just not just the self-help groups, but a game night, right? A substance-free game night for anyone to be able to go to. Sober tailgates, I see, are kind of a really popular thing. So this way of kind of expanding, you know, what the way we think about recovery and kind of the encompassing way that we think about recovery. You know, our collegiate recovery program, we have here at Stanford, you know, we have 5 different groups, you know, that again, and we probably still don't have enough. We're still not able to meet everyone's kind of needs, but I think we're definitely trying. But it is difficult. I mean, there's always that. I think the other thing that plays a big part of this is stigma. I mean, there's no doubt that people are afraid. People are afraid to you know, admit that they have a problem. They're afraid of you know, if they go to any kind of recovery service, you know, it means that they're kind of stepping over that line, that, you know, they can never go back and use substances again. And that's a huge step. And so I think maybe hopefully trying to reduce those barriers to really invite individuals across the spectrum to, you know, into recovery, into collegiate recovery services is an important one.
Great, thank you. The next question is from Billy, and they are just asking, what is a good book for me to read on this topic?
Oh man, yeah, I don't know. They're really. I know that Lisa Laitman put a book out talking about kind of. I think it was geared more towards stories. There is a book in 2006. You have my. Just write down my email address right there and reach out to me. I'll send you. I believe the book is actually available online for free. I'll send it to you. And again, it is a little bit outdated. It's kind of based on some of the earlier work they did at Texas Tech. And that's why this toolkit really is so important. I think that this will hopefully speak to kind of the advances that have happened in the last few years on collegiate recovery programming. And you know, it really is sad that there's not a whole lot of books out there that I can point you to.
All right, thank you. And so the next question we have from Robert, what is that question you rephrase to administrators when asked how many students are you serving?
So again, you know, obviously each school may be different, but I think that when the burden is always placed on the program to prove their worth, right? In colleges, for some reason, we're really focused on, you know, prove that students need this service, right? And so I think that there are no doubt that students need these service, right? We need spaces that are destigmatizing for substance use disorder. And so what I generally will say to a college administrator in that situation is, you know, how many students are you serving? I turn it around on them and ask them, what does your recruitment efforts look like? How many students are you recruiting in recovery? What do your recruitment advertisements look like? Are you saying that we welcome students in recovery? We have services for students in recovery. Like I say, there's no doubt. I mean, Texas Tech, Rutgers, they proved for many years that students in recovery look for a place that's going to be safe for them. So there is no doubt that recovery and addiction exists in our society. It's what are you doing to make your campus a recovery-friendly environment? And so this is really a school-level intervention. And so those are my first questions: is what I don't know, what are you doing to recruit those students?
Thanks, Noel.
Great, okay. The next question we have, I work in harm reduction in Canada, and we would love to see more or any low barrier recovery options for the people we see. Why isn't there accessible options for people?
So that's a very large, encompassing question that it will be impossible for me to answer in the 2 minutes that I have. I think that this is a very complex problem. I think, you know, one of the things that the recovery program here at Stanford really prided itself on was having an all recovery meeting. And that means all recovery in that anybody in any phase of the recovery process can come to that. We have other meetings too, but that is the central meeting that we have really prioritized the entire time here on campus. And so, you know, I think that it helps people like break down some of those barriers. I do think that, you know, we're playing catch up, especially on the harm reduction side of things. I think that you know, a lot of times what's happened, I think, is that the research has moved much faster than, you know, society's preferences. And while that is a very sad kind of state of affairs, we're in a state right now where we're having to kind of meld those two things together or bring those two things together. And it's a very difficult thing to do. I you know, I have friends that you know, have made a living in harm reduction, and that is their life's goal, to create and serve those people. And they're, you know, they sometimes have a very, I guess, again, we kind of live in a polarized society right now, where, you know, those two things, for some reason, harm reduction and recovery, seem to be at polar opposite ends. I don't view them that way. I definitely view more of a centrist on that, but it's a difficult world that we live in that, you know, we tend to argue more than we agree. And so I don't have the answer for that. I wish I did. But I'm hoping that we're moving towards solutions. I think that collegiate recovery programs can be a huge benefit in that area.
Great. Okay, and we are just about at time. It's 1 o'clock. So apologies if we did not get to your question, but I'll make sure to download this Zoom chat and send it to Dr. Vest. And if you have any further questions, feel free to email, and I will email out everybody by the end of the week the video recording for this presentation along with the slides. And just thank you so much, everyone who came out today for the ORN webinar. We hope to see you in December. Have a great rest of your day.
Thanks, everyone.